Hi, this is Matthew Kruse with Creighton Radiology, and welcome to the mini lecture on prostate cancer imaging. In this lecture, I'm going to touch on several radiotracers that are used in prostate cancer imaging. We'll discuss the indications, the practical points of the imaging procedure, and some basics of interpretation. The first nuclear medicine test we'll discuss is the technetium bone scan. This has been a mainstay of prostate cancer imaging for many years. The most common agent is technetium-99m methyl diphosphonate, or MDP, and this tracer works by attachment to the hydroxyapatite, basically calcium phosphate matrix of bone, specifically at the sites of increased bone turnover, such as osteoblastic metastasis. The indications in prostate cancer are for initial evaluation of high-risk patients, detection of recurrence, and monitoring response to therapy. This imaging procedure involves an IV injection of the radiotracer followed by a 3 to 4 hour uptake time. The imaging itself takes approximately 20 to 30 minutes, and the patient's instructed to maintain oral hydration and empty their bladder prior to imaging. Some basics of interpretation for the technetium bone scan. This is a very sensitive test, but not a specific test for osteoblastic metastasis. Other causes of increased bone turnover, such as healing fractures or degenerative changes, would also have increased uptake on bone scan. We determine if an area of uptake is suspicious based on the pattern of uptake with the overall appearance of the bone scan, as well as correlating with anatomic imaging, mainly CT. We use these two factors to differentiate metastasis from degenerative or traumatic uptake. Next, let's go over some bone scan examples. This is a normal bone scan. You can see that traditionally a bone scan is displayed by a whole body anterior and posterior view. There is slightly increased uptake at several joints, for example sternoclavicular joints and sacroiliac joints, which is still within the normal range. The IV injection site can be seen in this patient in the left antecubital fossa. At the right of the slide is a patient with degenerative disease. You can see there is more prominent uptake at the shoulders, the wrists, and the left knee. There's also increased uptake at the ankles and at several areas within the feet. These are uncommon sites of metastatic disease and very typical in appearance for degenerative changes. Another cause of non-malignant increased radiotracer uptake on bone scan is prior trauma. At the left side of the slide, we see a patient with several right anterior ribs that demonstrate increased uptake. This sequential pattern is typical of rib fractures. The healing response and sclerosis results in increased uptake with the technetium bone scan radiotracer. At the right of the slide, we do see a positive bone scan for prostate cancer. You can see that there are multiple foci of intense increased radiotracer uptake throughout the spine, within multiple ribs, within the pelvis, and within the left proximal femur. Metastatic disease typically involves the axial skeleton, spine, pelvis, and ribs, although in some patients it can involve the proximal extremities. Next, we'll discuss several PET tracers that are used in prostate cancer imaging. This is a list of all the PET tracers available for prostate cancer. First up is F18 sodium fluoride. This is a sodium fluoride bone scan very similar to the technetium bone scan we just discussed, but with increased sensitivity and using a PET CT scanner. Next is F18 fluciclovine, or trade name Axumin. This is an amino acid analog which detects lymph nodes and other sites of metastatic disease. This takes advantage of the fact that prostate cancer has upregulation of amino acid metabolism. The two tracers that we'll be focusing on are the state-of-the-art PSMA tracers. These are gallium-68 PSMA-11 and F18 DCF-PYL. PSMA PET tracers tend to have various names, and I've listed them here. The gallium-68 PSMA-11 tracer has a trade name of Locomets, and the F18 DCF-PYL tracer has a trade name of Pylarify. The gallium-68 tracer was approved by the FDA in December of 2020 and the F18 tracer in May of 2021. These are both molecules that bind to prostate-specific membrane antigen, or PSMA. This is a transmembrane glycoprotein that is overexpressed by 10 to 80 times in prostate cancer when compared to normal prostate cells. The indications for these tracers are listed below. They can be used for initial staging, biochemical recurrence, or detection of progression of disease. The imaging procedure is similar to other PET scans in that the patient receives an IV radiotracer injection and then has a 1-hour uptake or waiting period. The time on the scanner is typically 20 to 30 minutes. Some quick notes on interpretation of PSMA PET. At the right of the slide is a normal distribution of a PSMA PET tracer. This is a three-dimensional MIP or MIP image showing you the PET data as though you're looking at the patient from anterior projection. You can see there's physiologic uptake in lacrimal and salivary glands, mild uptake in the liver and spleen, mild bowel uptake, intense uptake in the kidneys with some additional excretion of the tracer within the urine. We interpret these scans by looking for sites of focal activity that is greater than background activity. One pitfall is that these tracers can show mild uptake in parasympathetic ganglia. This can be in the lower neck region or surrounding the adrenal glands. These tracers are known as a one-stop shop for prostate cancer imaging. They have a high accuracy for local disease within the prostate, for lymph node metastasis in the pelvis or retroperitoneum, or for the uncommon solid organ metastasis such as liver or spleen, and also increased uptake in bone disease. This is an example of a positive PSMA PET scan. At the left of the slide you see the MIP image with multiple foci of abnormal radiotracer uptake, which are pointed out with the red arrows. At the right of the slide we'll see fused PET and CT images in axial plane showing you the location of all these abnormal foci. From left to right, the abnormal foci are seen in the right lower rib, in a lower thoracic vertebral body, in the right ilium, in a mesorectal lymph node within the left pelvis, and in a right iliac lymph node. This is an example of a positive PSMA PET scan using the F18 tracer Pylarify. On the left-sided MIP image, you can see there are multiple abnormal foci of radiotracer uptake in the pelvis. These likely represent iliac and retroperitoneal lymph nodes, as that is a common site of nodal disease. There's an unusual site of disease indicated by the straight red arrow in the left lower neck, which is an involved left supraclavicular lymph node. The red arrowhead also indicates a left lower rib osseous metastasis. PSMA PET scans may quantify the patient's disease into low, intermediate, or high tumor burden, as indicated by these three separate patients. This may be helpful in stratifying patients in terms of their prognosis as well as treatment options. Finally, I'd just like to mention a newly approved treatment radiotracer for prostate cancer, and that is lutetium-177 PSMA-11, trade name Pluvicto. This was FDA approved in March of 2022. It's indicated for metastatic castration-resistant prostate cancer in patients who have been treated with prior androgen receptor inhibition and taxane chemotherapy. This uses the PSMA tracer to localize to sites of prostate disease, but instead of an imaging radionuclide, it uses lutetium-177, which is a beta emitter. Beta particles are higher in energy and radiate the tumor with minimal toxicity to normal tissues. This concludes a brief presentation on some of the imaging and treatment of prostate cancer with regards to nuclear medicine. Thanks.